Hello, I'm Dorothy Leland, president of LymeDisease.org. It's my pleasure to introduce Dr. Richard Horowitz, one of the most experienced and compassionate Lyme specialists in the world. Over the past several decades, he has treated more than 13,000 patients with Lyme and complex chronic illnesses, bringing clarity, validation, and hope to countless families searching for answers. Dr. Horowitz is also a best-selling author whose books, Why Can't I Get Better and How Can I Get Better, have become essential guides for patients navigating chronic Lyme disease. His forthcoming book, Ending Chronic Illness, continues that mission. It offers new insights into the root causes of persistent illness and empowers patients to advocate for their own healing. In addition, Dr. Horowitz shares timely research updates, clinical insights, and patient-focused commentary through his Substack, where many in the Lyme community follow his ongoing work. We're truly honored to have him with us today. Dr. Horowitz?
Thank you, Dorothy. So welcome, everyone. This is a really exciting webinar for me. I kind of backed into the information I'm about to share with you tonight. It was not like I had set out to try and find an answer for Alzheimer's disease. And I want to share with you, first, actually, let me thank the organizers, because I will tell you, and you probably know for webinars like this, it's a huge amount of information. So I want to thank Dorothy and Leah and Monica and everybody who's been part of this, the Colorado Tick-borne Disease Association, Minnesota Lyme Association, LymeDisease.org, and the Greater Kansas City Lyme Disease Organization. They're all doing great work, and I want to thank you for all of your efforts in helping chronically ill patients. I also want to thank the researchers, Eva Shapi, who helped me with a lot of the research you're going to see tonight and stimulated some of the ideas of how I actually came up with the study on how to reverse Alzheimer's biomarkers. A lot of this came out of the studies that was done by Alan McDonald and Judith McCloskey and Eva Shapi, including work that's come out of also of other universities like Monica Ember's group from Tulane, showing that rifampin and dapsone cures Lyme disease in mice. So everything I'm about to share tonight is not just coming from me. It's coming from all of the work that all of these researchers have been doing for decades, working for the Lyme community. And this presentation tonight represents truly a breakthrough. I don't think in the Lyme community, I've had my ear to the ground for a long period of time. There's really not been a lot talked about the relationship between Alzheimer's disease and Lyme disease. We obviously know that most of the people who suffer with chronic Lyme, one of the major issues they have, apart from fatigue, migratory joint pain, migratory nerve pain, tingling, numbness, burning, stabbing, migratory muscle pain, is memory concentration problems, word finding problems, going into rooms and forgetting why they walked in, sleep disorders, difficulty falling asleep, waking up. So cognition has always been one of the major things that has happened from chronic Lyme disease, as well as also can happen with Bartonella very frequently, mold toxicity, and many of the MSIDS factors that I'll be discussing with you tonight. But the thing that's remarkable about the study I'm about to present to you is when I submitted the journal article to the Journal of Alzheimer's Disease Reports, I didn't realize at the time that no one in the world literature had ever reversed a specific Alzheimer biomarker called p-tau217. So I'm presenting this to you tonight because before I finished clinical practice, which is only about 5 months ago, it seems like it's ages, I was finding probably about half of my Lyme patients were testing positive for these Alzheimer's biomarkers. And I'm going to show you some of the cases tonight, ones that were not published, but kind of give you an example of what I'm seeing in my practice. And I spoke with another doctor who I've consulted with to help her with her patients, and she told me it was about a third of her patients were testing positive for low beta amyloid 40-40 ratios, p-tau 181 was high, p-tau 217 was high, neurofilament light. I'm going to explain to you what these biomarkers are, what their significance is, and then I'm going to show you the research in the case study that we published just a couple of weeks ago in the Journal of Alzheimer's Disease Reports. So let me share with you I'm requesting to please open up my PowerPoint. There we are. Okay, great. So what we're going to discuss during tonight's webinar is Lyme and Alzheimer's disease. And I had thought before that there was a definite relationship between Lyme disease and Alzheimer's, but it had never actually been proven. It was a hypothesis that there were infections in the brain which were causing amyloid deposition. Most of you, I think, know that amyloid is one of the hallmark biomarkers for Alzheimer's disease, and that elevated p-tau, phosphorylated tau, was seen. And I thought that, gee, this had kind of been established because we knew syphilis, for example, a spirochetal infection had been associated with dementia. But as I'll show you, it was a hypothesis. And it was all based on autopsy studies because no one had ever reversed it in a live person. And that's what I'm going to show you tonight for the first time. I'm going to show you and prove to you the infection amyloid p-tau connection and the fact that in the article that we published in the Journal of Alzheimer's Disease Reports, I showed that all 16 MSIDS factors that I have been publishing for the last 20 plus years on chronic Lyme disease and also long COVID are also associated with Alzheimer's dementia. So let me first discuss financial disclaimers and conflicts of interest. So I have received royalties from St. Martin's Press for my New York Times national bestsellers, Why Can I Get Better and How Can I Get Better? I've received grants from the MSIDS Research Foundation, msidsfoundation.org, for the publication of the present article in the Journal of Alzheimer's Disease Reports and prior articles published in Antibiotics and Microorganisms. I'd like to thank Bay Area Lyme also in the past, who has provided also research funds for some of the articles that I published also in the past. I've received financial support from Simon & Schuster for my new science book, Ending Chronic Illness, which discusses Alzheimer's disease as well as other chronic illnesses. And to my surprise, and I'll tell you about this at the end of the presentation, when I did a deep dive in the scientific literature, what I discovered is almost every major disease on the planet had all 16 MSIDS factors, which now means we have new ways of preventing, diagnosing, and treating chronic illness. So in my new book, Ending Chronic Illness, if you are a Lyme patient, for example, who suffers from bad migraines, you'll see under the chapter P is for pain. I will explain to you how all 16 MSIDS factors are affecting pain syndromes and migraines. If you're a patient with Crohn's or ulcerative colitis, under D is for digestion. I will show you how all 16 MSIDS factors are associated with inflammatory bowel. And if you happen to be a Lyme patient who's received these Alzheimer's biomarkers from your neurologist being elevated, and you were started on a monoclonal antibody like lecanemab or donanemab, which we're going to discuss tonight, I'll show you that although these anti-monoclonal antibodies can be effective in lowering down amyloid and p-tau, the fact is that if we have an infection that is driving amyloid and p-tau, we may be able to increase the efficacy of these drugs that have been out there. And I'll show you the Cochrane report that came out 1 week before my article saying, hey, we really need new ways of treating Alzheimer's because the estimates are that over 55 years old, 42% of the population is expected to have ongoing dementia. I mean, huge numbers, which is why this is a really important presentation for tonight. Finally, I would just like to say, because I've worked for HHS and I've worked for the New York State Department of Health, that nothing that I'm going to share with you tonight reflects the views of either organization. So why should we pay particular attention to our brain health? So years ago, I saw this and I couldn't believe the numbers, but 46.5 million Americans were told they have preclinical dementia. Alzheimer's disease rates are expected to double and even triple in the next several decades. A 2025 scientific review, which I'll show you from the NIH, demonstrated that the risk of becoming demented over 55 years old is now 42%, which means that roughly 4 out of 10 people listening to this talk are expected to get a diagnosis of dementia. But as I will show you, not if you follow the recommendations that I will share with you tonight on how we reverse inflammation in the brain. So despite these alarming statistics, nothing is being done on a global public health level to address our dementia epidemic. And part of the reason is no one has ever shown definitively that we have a Lyme epidemic and we have an Alzheimer's epidemic, and somehow the two of these are related, and that's what I'm going to show you tonight, which means our public health authorities finally have a doorway, a light in the door just starting to open, that we may have new ways of helping a lot of these patients with dementia that we did not have before. And I'll also show you why using the 16 MSIDS model can help. So this is from the NIH. This just came out last year. the risk and future burden of dementia in the United States, where researchers estimated that 42% of Americans over age 55 will develop dementia. They're saying it's the aging of the US population that's causing the number of new dementia cases, but it's not the aging of the population. From my perspective, it's the MSIDS factors. It's infections. It's Borrelia burgdorferi. It's chlamydia pneumonia. It's Helicobacter pylori. It's viruses like certain herpes viruses. It's parasites like toxoplasmosis. It's fungal infections. I'll show you how all 16 MSIDS factors have been associated with Alzheimer's in the medical literature. So what exactly has been the Lyme-Alzheimer's connection that's been discussed before? So up until now, it's been a theoretical association that Lyme and Alzheimer's disease are related. Why do we think that? Because spirochetal infections like syphilis are well-established causes of dementia. Denticola spirochetes from our mouth have been established as a potential bacterial cause of Alzheimer's dementia. H. pylori, that helical spiral-shaped bacteria, potentially causing gastritis, gastric ulcers, and even gastric cancer, is a known potential cause of Alzheimer's dementia. And Borrelia burgdorferi, Lyme disease, has been implicated as a potential cause based on autopsy studies of individuals who died of either Alzheimer's disease or Parkinson's disease. So this just came out last month as a preprint. This is coming out of Finland and also Harvard University. Innate immune evasion of Borrelia drives Alzheimer's-like pathology. So we know that Borrelia induces molecular changes in the brain compatible with Alzheimer's disease. What they state in this preprint is collectively these findings provide a direct mechanistic link between pathogen immune evasion, amyloid beta dynamics, and neuroinflammatory cascades, advancing our understanding of infection-induced neuropathology, offering insights into novel potential therapeutic targets for Alzheimer's and neuroborreliosis. So what they discovered, and which has been in the literature, is that amyloid beta doesn't just show up in your brain. It's an antimicrobial peptide. It's showing up there in some cases because it's trying to prevent the infections from causing inflammation in your brain. But complement attack is stopped when Borrelia gets into the brain. Neuroinflammation increases, and Borrelia manages to evade the immune system. So let me explain to you the biomarkers that we published in the Journal of Alzheimer's Disease Reports so you understand exactly what we're discussing here regarding phosphorylated tau and amyloid beta. So amyloid beta peptide comes from amyloid precursor protein, or APP. This is a larger sticky protein in the fatty membrane surrounding nerve cells. Amyloid beta can form plaques and clumps in between neurons, disrupting neurological function. Amyloid beta is believed to be a primary cause of Alzheimer's disease, along with hyperphosphorylated tau microtubule proteins forming neurofibrillary tangles. So the primary pathology found in Alzheimer's disease is extracellular amyloid beta plaques and intracellular neurofibrillary tangles. Amyloid beta and p-tau are the key biomarkers and predictors of Alzheimer's disease. Now, it's interesting, when I was finding low beta amyloid ratios in my Lyme patients and elevated p-tau 181, p-tau 217, I was initially thinking to myself, oh, it's because Borrelia is causing neuroinflammation, causing these pathological proteins to go up. What I was not making the association, even myself early on when I started seeing this, is that someone else looking at this, like if a neurologist had seen this, they would have told my chronic Lyme patients that they have Alzheimer's disease, that they're going to go on and develop a full-blown case of dementia. So the four major Alzheimer's biomarkers we're going to discuss tonight is amyloid beta 42/40 ratios, p-tau 181, p-tau 217, the most sensitive and specific biomarker, and neurofilament light. And interestingly enough, the one in my patient that I completely reversed and lowered by 63% in 9 weeks using the 9-week Dapsone protocol was p-tau 217. So these Alzheimer's disease biomarkers are reflecting specific pathophysiological processes involving amyloid deposition, tau phosphorylation, and neuronal injury. Now, the amyloid beta 42/40 ratio is used to diagnose Alzheimer's. So if you go to Quest Laboratories, and that's how we did it in our patients, And you saw a low, not elevated, interesting low, because a low beta amyloid 42/40 ratio means you were depositing the stickier beta amyloid 42 in the brain. So you're actually, a low ratio is actually indicative of going on towards Alzheimer's with amyloid deposition. But if you have a low amyloid beta 42/40 ratio, that is how they diagnose Alzheimer's. They don't have to do it anymore with a spinal tap or a PET scan. So when determining the diagnostic accuracy of getting a plasma amyloid beta 42/40 ratio, in the studies, they compared it to PET scans, which are expensive and time consuming, and they did this in a cohort of 465 patients. And what they showed in this study is that it proved it is a robust measure for detecting amyloid plaques and can be used in the diagnosis of Alzheimer's. So if, for example, your neurologist wanted to get you one of these monoclonal antibodies like lecanemab or donanemab to try and take the amyloid beta plaques out of your brain, they would use a low amyloid beta 42/40 ratio. Just this blood test you can get from Quest, and I'll show you the biomarkers and how to order them at the end of this PowerPoint. So in Alzheimer's, what happens is the amyloid beta 42/40 ratio goes down, and as the amyloid is being deposited, the p-tau 181 and p-tau 217 go up. So again, the amyloid beta 42/40 ratio is lowered as amyloid beta 42, this is the sticky form, becomes sequestered in brain plaques. And this occurs while phosphorylated tau, both p-tau 181 and p-tau 217, increase in response to this amyloid pathology, and tau aggregation happens, with also an elevation of another biomarker called neurofilament light chain, which also happens with axonal damage. Now, neurofilament light is a nonspecific damage marker. So unlike amyloid and tau, which are specific to Alzheimer's disease, neurofilament light is nonspecific as a marker of neurodegeneration and axonal damage. So what is neurofilament light? So it's an axonal scaffolding protein, which is needed for the growth of our axons, for stability and synaptic organization. When a neuron dies or is damaged, neurofilament light leaks into our CSF, our cerebral spinal fluid and blood. So what it does is it functions as a nonspecific marker of neural axonal injury. But there are other conditions with elevated Alzheimer's disease biomarkers that I need to share with you, so you don't think if you comes back elevated that you definitely are going to go on and develop Alzheimer's. That is not necessarily the case. For example, in ALS, Lou Gehrig's disease, it has the highest NFL elevations among all the neurological conditions. MS has moderate NFL elevations, but much less than ALS. Frontotemporal dementia, NFL is often higher even than in Alzheimer's disease. In a stroke, you can get an acute transit NFL elevation depending on the infarct size and timing. In dementia with Lewy bodies, about 2/3 will show elevated Alzheimer biomarkers in their CSF. And in Creutzfeldt-Jakob disease, you can get a high total tau with a relatively normal p-tau. Now, interestingly enough, there are some patients, and I've seen this in the chronic Lyme patients that I was seeing right before I finished practice, which are what are called A-T+. This means that you're not making amyloid, but you have elevated p-tau. So this is normal elevated p-tau, and that's in 20% of cognitively intact adults presenting this way and may represent non-Alzheimer's tauopathy. Now, again, I suspect we're going to be finding this in a lot of the chronic Lyme patients because that's also what I was seeing before I finished practice in these, again, roughly 50% of the patients I was testing, is it wasn't always the amyloid beta ratios that were off where I had a low ratio. It was elevated p-tau 181 or p-tau 217 without low beta 42/40 ratios. So this is what I'm seeing in some of my chronic Lyme disease patients, as I'm about to show you. But other medical conditions, anemia, chronic kidney disease, cardiovascular disease, with inflammation. So again, it doesn't matter where the inflammation is coming from. If it elevates one of our chemokines and cytokines that we see in Lyme, IL-6, and you may remember from some of you who followed me before that there's a switch in the nucleus called NF-kappa B. And this is one of the major switches in the nucleus that turns on inflammation. When you turn on this switch because you have infections, whether it's COVID, whether it's Lyme disease, it elevates inflammatory cytokines like TNF-alpha, but also interleukin-6 And this can also increase Alzheimer's disease biomarkers, including total tau, p-tau, neurofilament light, and another marker of brain injury called glial fibrillary acidic protein. This comes from astrocytes in the brain and is seen in autosomal dominant Alzheimer's about 10 years before people start noticing problems with their memory. So GFAP is also a marker that can be used in autosomal dominant, meaning your ApoE44. If you use this specific marker, it'll tell you 10 years before that you better get on it and you better figure out ways of lowering inflammation. So the real question is, these are all inflammation is causing these Alzheimer's biomarkers to happen, but where is the inflammation actually coming from? So let me show you some patient examples in my medical practice of elevated Alzheimer's disease biomarkers. So the first patient I'm going to share with you is a 77-year-old female who had a past medical history significant for chronic Lyme disease, babesiosis, cytomegalovirus, herpes simplex virus. She had elevated heavy metals with lead and aluminum, low vitamin D, metabolic syndrome, obesity, sleep apnea, and she had inflammation. So these are all, by the way, known MSIDS factors that can raise Alzheimer's disease biomarkers. Her main complaints when she saw me was fatigue, pain, and problems with memory and concentration. Now, she got through about 5 weeks of dapsone. She never finished it. Her CRP was elevated, which is an indirect marker of IL-6 elevation. And if you look on the right-hand side, you'll notice her p-tau 181 was elevated at 1.36. Her p-tau 217 was elevated at 0.3. So in patient 1, she had a tauopathy, right? She was A minus T plus from chronic Lyme disease and overlapping MSIDS factors, meaning the inflammation in her brain was coming from multiple sources: infections, heavy metals, lack of sleep with sleep apnea, an increased hemoglobin A1C with metabolic syndrome, obesity, and low vitamin D. And again, she did feel better after doing dapsone combination therapy with less fatigue. She was less symptomatic, but she never finished the protocol and her Alzheimer's biomarkers were elevated. Patient 2 is an 89-year-old white male. He has a history of hypertension, hyperlipidemia, metabolic syndrome, chronic kidney disease, anemia, monoclonal gammopathy of unknown significance, which can cause an anemia where the hemoglobin's around 10.5 with chronic Lyme disease. And he was complaining of memory and concentration problems. So again, in this patient, his beta amyloid ratios, you'll notice, were normal. He had a tauopathy. He was A minus, T plus. He had an elevated p-tau 181, about 4 times above normal, quite high, and an elevated neurofilament light. Now, again, we just told you that anemia and chronic kidney disease can be associated with elevations in p-tau 181 and neurofilament light. And midlife hypertension and diabetes can also be associated with more rapid rises in neurofilament light. Now, both of these patients that I'm sharing with you, patients 1 and 2, were ApoE33. This is not the genetic subtype normally associated with Alzheimer's disease. And unfortunately, he was unable to do dapsone combination therapy because of the anemia. I did discuss with the family and his new doctor that theoretically he could get 2 units of packed red cells to do it. But at this point, he turned 90 years old. He's got other medical problems. Patient 3 is a 77-year-old white female. Past medical history significant for chronic Lyme disease, active Bartonella, hypertension, hypothyroidism, and mold toxicity. Her chief complaints when she saw me was fatigue, insomnia, migratory joint pain. Again, we talked about earlier that migratory pain is the hallmark of active Lyme. She had neuropathy as well as memory concentration problems. She took low-dose minocycline, 50 milligrams per day, and low-dose dapsone at a dose of 25 milligrams per day for 1 to 2 years. She did not want to do double-dose dapsone because she was worried about Herxheimer reactions at her age. Now, she did say to me, "Doc, my brain is much clearer, even with very low-dose minocycline and low-dose dapsone." But after about a year and a half of doing it, we stopped the drugs and she relapsed, noticing her cognition got worse. We checked her Alzheimer's disease biomarkers, and you can see on the right, the p-tau 181 was elevated at 1.74, and her p-tau 217 was elevated at 0.18. And again, ApoE33. We're not talking about a genetic risk for Alzheimer's, and her neurofilament light chain also was elevated. So why did these 3 Lyme patients that I just shared with you, who all had borreliosis, some of them with mold and Bartonella. Why was this happening to their brains? What does Borrelia do to the brain to cause increases in amyloid beta and elevated p-tau production? So central nervous system inflammation happens through a multi-layered process. There can be direct meningeal colonization, which can result in a Lyme meningitis. There's blood-brain barrier disruption, which also happens with imbalances in the gut-brain axis, such as in those patients with leaky gut, intestinal hyperpermeability, which is probably about 50% of the chronic Lyme patients I've been seeing. And then what happens is there's a marker called LPS, lipopolysaccharides, that gets across this leaky gut. It translocates into the bloodstream. It makes the blood-brain barrier even more permeable, and it further increases inflammation. Then you start to get activation of these little microglial cells in the brain. That's, by the way, why I love low-dose naltrexone that I'll tell you about in just a little bit. And then it raises cytokines and chemokines in the brains, including IL-6, which is seen in both autism spectrum disorder and Alzheimer's disease. So again, we go back to the autopsy studies. Like, why has nobody ever before? Lyme has been around at this point. We've been talking about it for 50 years. But the reason we've never really made it is the association with Lyme and Alzheimer's, because it's always been in autopsy studies. So this goes back to the problem of association versus causation. So prior scientific studies have demonstrated a potential association between Borrelia burgdorferi, Lyme, and Alzheimer's, as the bacterial infection is a spirochete similar to syphilis, a known cause of dementia. Now, Judith McCloskey did a lot of work years ago from Switzerland on this, and what she showed, this is published in the Journal of Alzheimer's Disease, in a meta-analysis of case-controlled studies, there was greater than a 10-fold increased occurrence of Alzheimer's disease when there was detectable evidence of a spirochetal infection. So again, this is consistent with prior research showing that amyloid beta has antimicrobial properties. It wasn't just that the amyloid beta was showing up in the brain for no reason. It was actually trying to protect patients from the infection that was showing up in their brain. Again, this is again from Dr. McCloskey, historic evidence to support a causal relationship between spirochetal infections and Alzheimer's. And in that paper, her conclusion was several types of spirochetes are involved in the etiology of Alzheimer's disease, and that chronic neurospiroketosis can reproduce the clinical, pathological, and biological hallmarks which define Alzheimer's disease. So historical observations were supporting a causal relationship between a long-standing spirochetal infection and Alzheimer's disease. So then it becomes the issue is, well, okay, we're finding an association. So is Borrelia found in the biofilms of brain tissue? Like, is this maybe part of the problem? Because as we know, when we have Borrelia in biofilms, it can increase inflammation. So this was published several years ago by the Italian researchers, the emerging role of microbial biofilm in Lyme neuroborreliosis. So what they found is that Borrelia burgdorferi can form biofilm-like communities which are significantly more resistant to antibiotics and immune defenses. And as I will show you in dapsone combination therapy, not only are we using 4 biofilm agents twice a day in the protocol, but rifampin, minocycline, dapsone, and zithromax also affect the biofilm forms of Borrelia burgdorferi, which is likely why we had the success that we had when we published this journey in the Journal of Alzheimer's Disease Reports. So they did studies using fluorescent in situ hybridization, FISH, and immunohistochemical methods. And they identified Borrelia in biofilm-like highly resistant aggregates in the brains in autopsies, including cases of chronic neuroborreliosis. So the first clue that we have, if we want to try and get rid of Borrelia in the brain and try and prevent these Alzheimer-like changes with low beta 42/40 ratios, elevated p-tau, is we have to open up the biofilms to be able to get the antibiotics where they need to go. And it's especially important because biofilm forms of Borrelia have shown up to 1,000 times greater resistance to conventional antibiotics. Now, what stimulated me to do the study that I did, and I really want to thank Eva Shapi and Alan McDonald, God bless you, Alan, for all the work you did, and Sinjani from the University of New Haven, is Eva Shapi and colleagues published 4 years ago in the Journal of Alzheimer's Disease that Borrelia was co-localizing with biofilm, amyloid, and p-tau in the brain. So the study that they did along with published reports by Judith McCloskey, provided evidence for an association between Lyme disease, other spirochetal infections, subsequent biofilm formation, Alzheimer's pathology, and chronic neurodegenerative diseases. And again, prior evidence had always been based on brain autopsy tissues of patients diagnosed with either Alzheimer's or Parkinson's, but never an in vivo case study. So when I read the study by Eva, and this again just is to point out how beautiful the synchronicities and the synergy of all of the great research that has been funded by Barry Lyme and all of the Lyme groups out there, that Eva was able to publish this with Alan McDonald, the light bulb went off in my head when I started seeing these markers of Alzheimer's disease show up in my Lyme patients saying, hey, if Borrelia is co-localizing with biofilm amyloid and p-tau, and we know that dapsone combination therapy hits the biofilm persistiforms in the brain, right, or let's say in culture, what would it do actually in the brain of a live person? And here is the first in vivo proof of linking Lyme disease, Borrelia burgdorferi, and Alzheimer's. I just published it in the Journal of Alzheimer's Disease Reports at the end of April. It's called Improving Biomarkers of Inflammation, including phosphorylated tau in a patient with chronic Lyme disease PTLDS syndrome using dapsone combination therapy, a case study, and literature review. Abstract background. Borrelia burgdorferi, the agent of Lyme disease, has been found to co-localize in Alzheimer's disease autopsy tissues with biofilm amyloid and p-tau. Again, this comes right out of the work by Eva Shoppe's group at the University of New Haven. My objective was to determine whether dapsone combination therapy, a biofilm persister antibiotic regimen with good central nervous system penetration, can improve p-tau and also peripheral inflammatory markers in a patient with chronic Lyme PTLDS. Now, I want to point out how kind the universe was to me by giving me this patient. It is very rare in medicine that I get a patient with chronic Lyme disease PTLDS who not only had had an EM rash and failed doxycycline, but was ELISA positive, C6 ELISA positive, CDC IgM Western blot positive, CDC IgG Western blot positive, CDC IgG Western blot positive. She met every criteria that the CDC and NIH would want for chronic Lyme PTLDS. So she was a 67-year-old female with chronic Lyme PTLDS and also had exposure to Ehrlichia, Babesia, Bartonella, and Q fever Coxiella burnetii. She had been sick for 15 years. And I want to point out this woman had never done any antibiotics for 15 years with me. She was doing herbal therapies. She did not feel she was sick enough to do dapsone therapy. She was doing herbs, which were helping her. And she was complaining of some joint pain with elevated rheumatoid factors with some very mild cognitive issues. In fact, she thought her memory was good. She had been meditating and thought that was the reason her cognition was fine. So what I did is I followed her rheumatoid factors and changes in p-tau 181 and p-tau 217, as well as amyloid beta ratios before and after treatment with dapsone. The results: she had an elevated rheumatoid factor at 20, which decreased into normal range 3 months after treatment with dapsone. So the first thing we did is we know that the rheumatoid factors are not just a sign of rheumatoid arthritis, but it's a sign that a bacterial infection like Lyme, which is present in the body, is driving rheumatoid factors as a marker of inflammation. That was the first thing we did, is we reversed rheumatoid factors. Initially, elevated serum p-tau 217 in the blood at 0.33 picograms per ml, normal range less than 0.15, prior to dapsone therapy, normalized decreasing to 0.12 3 months after therapy, while p-tau 181 remained within normal limits. Now, what was fascinating is while the p-tau 217 came down, her amyloid beta ratio improved, increasing from 0.185 to 0.216. I mentioned to you earlier that an elevated beta ratio, 4240, is what you want to see, accompanied by subjective improvements in concentration and recall. Conclusion: this is the first case study proving that a short-term biofilm persister drug regimen, dapsone combination therapy, can potentially improve peripheral autoantibodies, rheumatoid factors, and pathological triggers of neuroinflammation, p-tau 217, amyloid beta, in a patient with chronic Lyme disease. So I showed in this article also for the first time that all 16 MSIDS factors are associated with Alzheimer's disease. So if you were someone diagnosed with dementia, now you have a new way of approaching it by saying, hold on, I need to go through all these MSIDS factors to find out where the inflammation is coming from. The other thing that's beautiful about this case study is it proves proof of persistence of Borrelia because the woman had not taken antibiotics for 15 years and got better with an 8 to 9 week dapsone protocol. And I didn't realize at the time, by the way, when I published this in the literature, it was the first time ever that p-tau 217 had been completely reversed to normal. It was lowered by 63%. I didn't realize that until after I published the article. So all 16 MSIDS factors are found in Alzheimer's. So what are these 16 MSIDS factors? Well, we have the 6 rivers of inflammation. We have infections, environmental toxins, microbiome abnormalities, leaky gut with intestinal hyperpermeability with mast cell activation, vitamin and mineral deficiencies, as well as sleep disorders. The downstream effects of these 6 rivers of inflammation is mitochondrial dysfunction, well known, by the way, to cause Alzheimer's disease pathology, immune dysregulation, autoimmunity, hormonal dysregulation, liver disease, neurological dysfunction, autonomic dysfunction, psychological dysfunction, pain syndromes, and deconditioning. So just as over the years, in all of my books and articles, I've been talking about these 16 MSIDS factors, and back in 2024, in Microorganisms, I published that the same 16 factors were associated with long COVID. For the first time, we've now proven that all 16 MSIDS factors are also associated with Alzheimer's. So the 16-point MSIDS map is now appropriate in chronic Lyme, long COVID, and Alzheimer's. And again, what you want to do if you're someone with neurocognitive complaints is look at the 6 primary inflammatory factors and the 10 downstream factors that are associated with it. So again, what are the 16-point MSIDS factors in Alzheimer's? So what's been published in the medical literature regarding infections causing Alzheimer's has been Borrelia, Lyme disease, chlamydia pneumonia, Treponema species, Porphyromonas gingivalis from your mouth, H. pylori and Coxiella burnetii Q fever. Viruses that have been associated with Alzheimer's include herpes viruses, HSV1, HHV6, Epstein-Barr virus, CMV, COVID, as well as hepatitis C virus. Parasites like toxo and fungal infections like Candida malaria. Environmental toxins like air pollution, fine particulate matter, PM 2.5, heavy metals and pesticides. Microbiome abnormalities with a decreased diversity and abundance of beneficial bacteria like Firmicutes and bifidobacteria. Intestinal hyperpermeability with leaky gut with or without mast cell. Vitamin and mineral deficiencies including vitamins B2, B6, B9, B12, vitamin D deficiency, E and copper, as well as sleep disorders, your 6 rivers of inflammation, and all 10 downstream effects of inflammation have also been associated with Alzheimer's, mitochondrial dysfunction, hormonal immune dysregulation, autoimmunity, liver disease, neurological and psychological dysfunction, POTS dysautonomia, deconditioning, and pain syndromes. Now, what's also fascinating about this is autism's older cousin turns out to be Alzheimer's disease. There is a genetic link between being born with autism spectrum disorder and getting Alzheimer's later in life, and it's called the mTOR pathway, the mechanistic target of rapamycin. So there are actually genetic and pathogenic overlaps between inflammation in the brain when you're young, autism, and Alzheimer's later in life. And you can see in this medical detective Substack image that we did, thank you, Stephen Bittrick, who's my AI genius, sulforaphane, which I'm going to talk to you about in a second, broccoli seed extract, extremely effective in autism and it can help with Alzheimer's. You need to look at vitamin D. Lithium was just published for Alzheimer's. Probiotics can be helpful. They also showed that increasing the vasculature in the brain using things like Viagra with PGD2, Keppra, osteoporosis drugs. So autism and Alzheimer's have generally not been linked up, but let me show you how they can be related. So the mTOR pathway is a shared genetic pathway between autism and Alzheimer's. The mechanistic target of rapamycin, it's a pathway that is an essential cellular signaling cascade that integrates diverse environmental and intracellular signals, including nutrients, growth factors, energy status, and oxygen levels to regulate cell growth, metabolism, protein synthesis, and autophagy. And it's really important to understand what is autophagy. Autophagy is the body's natural cellular recycling system. It breaks down and removes old, damaged, or dysfunctional cell parts like mitochondria and turns them into energy or new healthy components. It acts like a cellular reset button or a cleaning crew, essential survival. And they found that if you cannot have healthy autophagy, it affects autism and it affects Alzheimer's. So both autism and Alzheimer's have mTOR dysregulation as a shared mechanism. It's a convergent pathogenic mechanism, despite these conditions affecting different life stages and also presenting distinct clinical features. So the pathway's dysregulation disrupts critical neuronal processes, including synaptic function, protein homeostasis, and autophagy in both autism and Alzheimer's. In autism, this leads to abnormal brain connectivity patterns and increased brain volume. And we do see large brains macrocephaly, which is common in autism spectrum disorder. In Alzheimer's disease, mTOR dysregulation contributes to amyloid beta and p-tau elevation. So what they showed in Alzheimer's is that if this mTOR pathway is hyperactivated early on, you get amyloid beta production. It suppresses autophagy. So in other words, you can't clear these toxic protein aggregates in the brain. That means you don't clear your amyloid beta. You produce more of this hyperphosphorylated tau, and there becomes a vicious cycle of increased protein aggregates and impaired clearance mechanisms. And this goes along with problems with sleep with the lymphatics, because they discovered in the last couple of years, you have these lymphatics in the brain called glymphatics, that if you don't sleep well, you can't clear these toxic protein aggregates because you're just not getting good clearance by glymphatic drainage. Now, interestingly enough, literally 1 week before I published my article in the Journal of Alzheimer's Disease Reports, there was a Cochrane review where they showed that these amyloid beta targeting monoclonal antibodies were just insufficient for Alzheimer's disease and basically said we desperately need new treatments for Alzheimer's. It showed that amyloid beta targeting monoclonal antibodies, they do lower, by the way, p-tau 217, as I'm about to show you. I mean, it's not like there's no benefit, but there are some potential side effects with brain bleeds and swelling. And interestingly enough, and I think this needs to be done by the pharmaceutical companies, that it is possible that these drugs, lecanemab and donanemab, that have already been shown to lower p-tau by 23% over more than 6 years, you may increase the efficacy of getting rid of beta amyloid and lowering p-tau by treating infections like Lyme and still giving patients these pharmaceuticals, and may find that they're way more effective. That the reason some of these monoclonal antibodies weren't working properly is that some of these patients, and I'm estimating, and I'll show you why, I'm thinking it's probably going to be 30 to 40% based on the medical literature. So in the Trailblazer Alzheimer trial, which was published in JAMA Neurology back in 2022, the most that phosphorylated tau had ever been lowered in the past with these anti-monoclonal antibodies was 23% from baseline, and it took them 76 weeks, over 6 years, in the Trailblazer Alzheimer trial, while placebo-treated patients showed a 6% increase, representing an effective 29% difference in p-tau 217. What did I do? I completely reversed p-tau 217, not by 29% over 6 years, but by 63% in 8 to 9 weeks. And I didn't realize at the time I lowered the most specific and sensitive Alzheimer's biomarker using double-dose dapsone combination therapy. Now, what happened to my patient while I was lowering p-tau 217? So you'll see on the right, and this is all basically Quest Laboratories, it's their Alzheimer Detect Beta Amyloid 42/40 ratio. You'll notice the ratio is going up over time. And if you can read it in the slide, you'll see that it's a lower risk in the blue. So in other words, the higher you are in the blue, the lower the risk of getting Alzheimer's. So as the elevated p-tau 217 at 0.33 normalized to 0.12 3 months after dapsone combination therapy, decreasing by 63%, the beta amyloid ratio improved. And what's interesting is the p-tau biomarkers are more closely associated with amyloid beta plaques than tau neurofibrillary tangles. Because you might think, oh, p-tau 217 came down, that means phosphorylated tau is coming down in the brain. Not so. What it implies is that your amyloid is actually going down. So let's look at the significance of p-tau217 in Alzheimer's. And this is what kind of blew my mind after I published the study, realizing what I had accidentally done. Plasma phosphorylated p-tau217 is the highest performing blood biomarker for Alzheimer's disease, demonstrating an 88% sensitivity and an 89% specificity for detecting biologically defined Alzheimer's disease pathology, with diagnostic accuracy approaching that of amyloid PET scans and doing a spinal tap. And the primary MSIDS variables affecting this pathological protein beta amyloid in p-tau in our patient was infections, primarily Borrelia, but she also had Babesia, Bartonella, 2 species, by the way, Ehrlichia and Q fever, environmental toxins, heavy metals, lead and mercury, intestinal hyperpermeability, she had a borderline B12 level, and she had metabolic syndrome. These were the 5 main factors, but obviously because of the effect we had with dapsone, this 8 to 9 week protocol, it was mostly Lyme that was affecting it. But realize I had treated her Bartonella, I had treated her Q fever, I had detoxed her heavy metals. I treated her intestinal hyperpermeability. So all of these things, I treated her metabolic syndrome and replaced her B12. All of these things likely were playing a role. But again, dapsone was probably the most important. Now, when you read the study, there was a second patient in that published study that also had negative Alzheimer's biomarkers, but had ongoing memory concentration problems. You can see the markers on the right. And in this patient, she was a 58-year-old female. She had a past medical history for chronic Lyme with active Babesia and Bartonella by fish, right? This is a fish-positive patient, active. Elevated VEGF, indirect marker of Bartonella with vascular endothelial growth factor. She did the 8 to 9 weeks of double-dose dapsone with 4 pulses of high-dose dapsone, and her fish testing was negative. So for all intensive purposes, in patients, when I do the initial 9-week dapsone protocol, followed by 4 pulses, which are just 13 to 14 days, patients can get rid of Babesia, Bart, and Lyme. The fish testing was negative. And her Alzheimer's biomarkers were negative. But she had been exposed to West Nile. And she also had high mold and a low red blood cell zinc. So we talk about in the article the fact that West Nile, as a flavivirus, may be associated with ongoing inflammation in the brain, and mold also can cause a problem, obviously, with cognition and even cause mitochondrial dysfunction, a known cause of Alzheimer's dementia. Now, you might ask yourself, well, Dr. H, if you're using a tetracycline like Mino or Doxy and rifampin and Zithromax and dapsone in your protocol, and we did this, right? We looked at this in culture with Eva Shoppe, and I'll show you this in just a second. Has anyone looked at the drugs you were using to treat Alzheimer's disease? And the fact is, yes. They looked at this. They looked at Doxy, rifampin, dapsone, and Zithro. Look at the top of the right-hand corner of this slide where it says antimicrobial. You'll notice rifampin, dapsone, azithromycin, and doxycycline, exactly what I'm using to treat Alzheimer's. Back in 2018, they were talking about the fact that each one of these drugs individually had looked that they might have had some effect, but no one had ever looked at putting them together or what actually happened with p-tau217. But what they did look at, and this is absolutely fascinating, there was a 15-year study in Korea with Dr. Lee's group involving over 3,000 patients with leprosy, Hansen's disease, who took dapsone 100 milligrams a day for 15 years. They had significantly lower rates of Alzheimer's. I want you to look at the slide on the bottom right. The ones who took dapsone are in blue with Alzheimer's disease prevalence. The ones who did not take dapsone, those are the ones in red. You can see that there was a clear causal relationship. If they did not take dapsone, much higher rates of Alzheimer's disease prevalence with a p-value of less than 0.0001. It was statistically significant. Now, what did I use in the dapsone protocol in this patient that also supported brain health? And I'm just going to talk to you about one of these, but I'm also going to talk to you about, at the end of this, some of the things that are in my new book, Ending Chronic Illness, because I talk a lot about these nutraceuticals that support brain health. So sulforaphane glucosinolate broccoli seed extract, I want you to look at this for a second. There's a pathway in the body called the NRF2 pathway. I mentioned to you earlier that one of the first pathways driving inflammation is NF-kappa B. The second pathway that lowers inflammation when it's stimulated is called the NRF2 pathway. And this is a key player in stimulating antioxidant genes, lowering inflammation. Look at this, folks, restoring autophagy and supporting detoxification. And look what sulforaphane does. It modulates mTOR through the NRF2 pathways and enhances intracellular ATP production. And we know that we need more extracellular ATP for autism to get mitochondrial production enhanced. So mitochondrial dysfunction is a shared mechanism in both autism spectrum disorder and Alzheimer's, and sulforaphane broccoli seed extract is modulating mTOR and lowering inflammation through the NRF2 pathway. It helps with the gut-brain interaction. It helps lower neuroinflammation. It's good for the mitochondrial health. It hits NRF2. It goes across the blood-brain barrier, opens up detoxification, and lowers oxidative stress. So how important is sulforaphane broccoli seed extract in autism affecting the mTOR pathway? A landmark trial by Singh et al. In 2014 showed a 34% improvement in behavior, a 70% improvement on social responsiveness in young men with moderate to severe autism who received sulforaphane 50 to 150 microgram millimolar per day for 18 weeks, but the improvements reversed upon discontinuation. How important is sulforaphane in Alzheimer's disease? So the study published in the Journal of Alzheimer's and Dementia indicates that sulforaphane as an NRF2 activator is a viable treatment option for reducing oxidative stress in Alzheimer's disease. Neuroinflammation with glial cell activation is one of the key mechanisms underlying Alzheimer's pathogenesis, alongside classic hallmarks of amyloid beta plaques and neurofibrillary tangles. And I will point out that in the dapsone protocol, the way I wrote it up in the medical literature, you will see that sulforaphane glucosinolate is part of the protocol. Of course, I didn't realize at the time I was stimulating mTOR pathways and I was helping with this, but it turns out it was actually a good call years in advance. And again, other things you can do if you've been diagnosed with this is vitamin D, lithium, probiotics, even osteoporosis drugs. The literature is now starting to look at repurposed medications to help with people who have both autism and Alzheimer's. Now, I'm going to finish up the talk with showing you briefly some of the articles on dapsone combination therapy and why I believe for those Lyme patients out there that are still suffering, or someone who has been diagnosed with Alzheimer's using p-tau217, 181, beta amyloid, who has been exposed to Lyme, why I believe you should speak to your doctor about using dapsone combination therapy, the 8 to 9 week oral protocol with 4 pulses if you have Bartonella, and looking at these 16 MSIDS factors. So the article that I just published is the 11th article on dapsone in the peer-reviewed medical literature. So why do I believe dapsone combination therapy was so effective in reducing Alzheimer's biomarkers in our patient? Well, I showed you the article by the Italian researchers that it is these biofilm aggregates in the brain that are driving neuroinflammation. When Eva Shoppi's group and I published this article in BMC Research Notes 6 years ago, and we looked at how combining dapsone alone or in combination with other intracellular antibiotics worked against the biofilm forms of Borrelia burgdorferi, you'll notice at the bottom right of the slide that the 4-drug combo of a tetracycline doxy with rifampin, with zithro, and dapsone was the most effective combination at 72 hours. That 4-drug combo was the most effective in lowering down the biofilm persister forms of Borrelia. The other thing that dapsone does in the brain to lower inflammation is it acts as what's called an NLRP3 inflammasome inhibitor. I mentioned to you earlier 2 major inflammatory pathways called NF-kappa B and the NRF2 pathway. The third major pathway driving inflammation, and by the way, in my new book, Ending Chronic Illness, coincidentally, I'm going to show you there are 16 inflammatory pathways underlying these 16 MSIDS factors. It's a bit of a coincidence, but it's true. And dapsone acts as an NLRP3 inflammasome inhibitor. So what they discovered in this article, dapsone, more than an effective neuro and cytoprotective drugs, is in recent years its antioxidant, anti-excitotoxic, and anti-apoptotic effects have been described in different ischemic damage models, traumatic damage, and models of neurodegenerative diseases such as Parkinson's and Alzheimer's. Dapsone is proven to be a safe and effective drug And again, for the Lyme patients out there who've worried about this, it's been published in the literature to protect brain cells and neurons, to protect the heart, the kidneys, the liver. Dapsone is a safe and effective drug and protects the heart, renal, and pulmonary cell damage. And it's now employed in clinical trials as a neuroprotective therapy by regulating the main mechanisms. So again, what we're doing is we're hitting these stationary Fizz persisters in the biofilms that are driving inflammation. So many of you had given questions before this webinar, and I added these slides because many of you are asking that you were still sick. How are we supposed to get better? So I'm just going to run this through because this is really the key of how I've gotten these 13,000 chronic Lyme patients better. The most difficult to treat sensitive patients in my practice usually have certain things in common. They oftentimes suffer from multiple chemical sensitivity and don't detox well. They often have GI issues with disruption of the microbiome with SIBO, small intestinal bacterial overgrowth, gluten sensitivity, leaky gut, parasites, and enzyme deficiency. They have mast cell activations triggered by infections like Lyme. They have bacteria that are persisting like Borrelia and Bartonella, even Mycoplasma species, Tularemia and Brucella. We've rarely seen a case of a chronic rickettsial infection like Q fever, by the way, which our patient had exposed to. Parasites we've seen persist, of course, is Babesia, despite rotations of anti-malarial medications. Viruses we've seen persist is HHV6 reactivation with 4-time increases in titers and positive PCRs, and Epstein-Barr virus reactivation also in many of these low COVID patients, and chronic candidiasis. We've seen immune deficiency where 20% of our practice had immunoglobulin deficiencies, right? Chronic variable immune deficiency, low IgG levels, and 85% had subclass deficiencies. So you must check if you have IgA, IgM, and IgG subclass deficiencies and total decreased levels of these immunoglobulins. We see in some of our patients an immune overactivation with a lot of autoimmune markers and inflammatory markers. In 70% of our sickest patients, they had disruptive sleep patterns, including delayed sleep phase syndrome. They couldn't fall asleep for hours and kept waking up in the middle of the night. They had a circadian rhythm disorder with insomnia and hypersomnia, and a history of emotional trauma with PTSD and unresolved issues. They oftentimes had resistant POTS dysautonomia with severe autonomic dysfunction. Their vagus nerve had been affected. They had mitochondrial dysfunction with the cell danger response. They had difficulty finding a safe environment without continuous exposure to toxins, like when wildfire smoke was happening in California and in the Midwest. Or whatever underlying medical problem there was, including endotoxemia from dental GI sources, it was not well controlled and contributed to the burden of illness with genetic predispositions. So if we go back to the 200 patients on dapsone therapy we published in the literature, going back to 2017, this is 200 patients, and healthcare in 2018, the role of the MSIDS model in defining, diagnosing, and treating chronic Lyme and other chronic illness. And by the way, when I published this in 2018, I was aware this is going to apply to other chronic illnesses. I just didn't know in my new book, Ending Chronic Illness, that the MSIDS model was going to apply to most chronic diseases on the planet. But in all of these patients we were testing, it was 14 out of 16 MSIDS factors. In this particular cohort, we couldn't find a lot of mitochondrial dysfunction. That's mostly also because we weren't testing for it and we were treating it. And deconditioning may have not been playing as big a role. But it was like going into a doctor with 16 nails in your foot. You had to find all the nails for the patients to get better. So they had to address the infections, the 3Bs, Borrelia, Babesia, Bartonella. They had to address immune dysfunction with IVIG or subcutaneous immunoglobulin, lower inflammation by addressing these inflammatory pathways, addressing toxins like mold and heavy metals, dealing with allergies, taking care of any nutritional deficiencies, dealing with psych issues, like endocrine disorders with low adrenals or low testosterone, getting them to sleep, dealing with their POTS. All of these factors needed to be treated for patients to get better. So what we do in the dapsone protocol, and again, this is all published, I'm just going to point out how we created the protocol, is I block NF-kappa B with N-acetylcysteine, alpha-lipoic acid, and glutathione. I activate the NRF2 pathway with turmeric curcumin, green tea, resveratrol, and sulforaphane, broccoli seed extract. And I block the NLRP3 inflammasomes with melatonin, also, by the way, low-dose naltrexone. You can block activation of these microglial cells in the brain that turn on, causing neuroinflammation with LDN. So many of our patients were taking 4.5 milligrams of LDN, and if it kept them awake at night, they would take it first thing in the morning. This blocks NF-kappa B and TLR4 signaling, decreasing glial cell activation. We would have them on an anti-inflammatory diet with more omega-3 fatty acids and less omega-6s on a Mediterranean-style diet. We get them off their allergic foods. We would treat their SIBO and candida, get them off histamine foods, replace their minerals. We'd heal the damage to mind and emotions. I had many patients over time. I would say, please do the anti-hopper, dynamic neural retraining, or the Gupter AIR, amygdala insular retraining, or primal trust. If you do not get to some of this emotional dysregulation, which is thrown off by Lyme and BART and mold, it is very difficult to get better. So please make sure your doctor is integrating this into your healing program. We made sure we were opening up the detoxification pathways, removing chemicals like mold and metals. We were balancing the hormones, especially adrenals and sex hormones, and addressing the microbiome. Again, we were repairing the mitochondrial damage from free radicals. This is in the dapsone protocol, and treating and focusing especially on the 3Bs. So if you look at the published paper we did in antibiotics, going back, this is now almost 6 years ago, the efficacy of double-dose dapsone combination therapy, this is 100 milligrams of dapsone twice a day for 1 month, right? But it's an 8-week protocol. What happened to these patients? It was superior to lower doses of dapsone and led to long-term remission in almost 50% of patients, including patients sick for decades. So let me stop here just for a moment. We gave patients an oral protocol, 7 or 8 weeks. This is now double dose, just up to 200 milligrams, not high dose. And up to 45% of patients went into remission. But if you had PTLDS with an EM rash, the long-term remission was 58%. So roughly 1 out of 2 patients went into remission if they did this double-dose dapsone protocol, which was just 8 weeks. It was the first time in the medical literature we had shown a short-term antibiotic protocol was effective for chronic Lyme, and of course, we needed a multi-center, placebo-controlled randomized trial, which many of you probably know I did put in for an R34 NIH grant because I'm ready to prove this to the world, and it was turned down by the NIH, and I'm now looking for other funding because this must be done. This is the way we're going to basically prove this to the world and get you all better. But we needed to find effective treatments for Babesia and Bartonella because although dapsone combination therapy was highly effective for Lyme, if they had Babesia with these drenching night sweats at night, or sweats during the day, or air hunger, I can't catch my breath, or an unexplained cough, or shaking chills, and they failed Mepron azithromax or Malarone or other herbs, we now are using tafenoquine, 100 milligrams, 2 a day for 3 days in a row, 600 milligrams loading dose, and then 3 once a week for 6 to 8 weeks with 4 Malarone a day and 5 herbs like Cryptolepis, Japanese knotweed, Chinese skullcap, Acornia, and artemisinin. Now, again, this is all in my new book, Ending Chronic Illness, but you have to be G6PD positive to do tafenoquine just like you have to do dapsone. What was needed for BART was after you did the initial 9-week dapsone protocol, people every 2 to 3 months would do a 2-week pulse of high-dose dapsone combination therapy. Now, by the time you get to high-dose dapsone, this is only 6 days of dapsone at 400 milligrams a day. People will lower their counts by 2 or 3 grams of hemoglobin. It comes back very quickly because you're just on dapsone for 6 days. Now, microorganisms, September 2023, and April 2024 has the full protocol. And again, what I did in Ending Chronic Illness, I wrote this out as a cookbook for you. You'll see this when you eventually get the book. I wrote this out, including how you do low-dose dapsone, and if you have to start and stop, you do not lose the benefits. So why are we pulse dosing? Why am I telling patients do 8 or 9 weeks, stop, detox your mold during the time that you're not on dapsone, go back into a 2-week pulse? Because as I showed you, the biofilm persistiformis of Borrelia is mostly driving the inflammation in the body, whether it's inflammation in the brain or peripheral inflammation. Biofilms, they've shown this, like Staph aureus, can be sensitized to antibiotics by pulse dosing. So if you gave oxacillin every day, the biofilms did not significantly decrease. You had to start and stop the antibiotics. Now, many patients have said to me, I'm worried about doing dapsone because of the side effects. Please hear me clearly on this. I would never put out a protocol that was highly efficacious if it wasn't safe. There has never been one patient in my 41 years of clinical medicine where the labs did not come back to normal. So if you looked at the CBC and you looked at the hemoglobin, the average drop in hemoglobin was about 3.5 grams. Now, in some people, it was less. It might have been 1.6. In some, it was higher. It was 6 grams. But it always comes back to normal. So if you start with a hemoglobin of 14, you're likely to be around 10. It'll be back to 14 several months after you're done, right? Some people had what are called metamyelocytes or myelocytes, which are precursors of red cells. It turns out the ones that had that actually did better over time. Liver functions mildly bumped, always came back to normal. Some people, their total bilirubin went up. They had Gilbert syndrome, went back to normal. Their methemoglobin, on the average, was about 5%. Now, I designed the protocol with methylene blue, cimetidine, antioxidants like vitamin C, vitamin E, glutathione. All of these lower methemoglobin. So a methemoglobin of 5% on double dose or high dose dapsone, you feel a little short of breath with a slight headache. You've got blue hands and blue lips, but it's extremely tolerable. A dangerous methemoglobin is 50 to 60%. The average is 5%. Sometimes it'll be 8 or 9%. The point being, you don't have to worry about methemoglobin. I've got it covered in the way the protocol is done with methylene blue. There is no good reason, in my opinion, if someone is still sick with chronic Lyme disease and you've been doing herbs or other treatments, and especially if you have these Alzheimer's biomarkers, you need to be considering this protocol. So how do we prevent harm? Herxes, anemia, rashes, and methemoglobinemia. So built into the protocol is things like low-dose naltrexone, the BLT formula from Research Nutritional with Smilax, a saparilla that keeps down herxes. We give people high-dose glutathione. We give them detox support. And again, we're using those first three pathways. We're blocking NF-kappa B, we're blocking NLR3 inflammasomes, and we're stimulating NRF2 so that you can get through the protocol more easily. And in some patients, if you have to pulse the dapsone and start 25 every other day and go slower, it doesn't matter. Even if it takes you longer to work up the dose, you'll still get the benefits of this protocol. If you stop, let's say, at 100 milligrams, because you're a woman starting with anemia, and you picked up the protocol 1 to 2 months later and went back at 100 milligrams, you're not going to lose anything, because once you lower the biofilm persisters to a certain level, from what I've seen, they don't grow back. You start back at where you left off, you'll pick up and get benefit from it. And I've definitely seen this over time. But you need to address any iron deficiency, B12 deficiency, or folic acid deficiency before you do dapsone. You have to make sure you're G6PD positive with the enzyme. But again, rashes, if you said, oh, I'm allergic to Bactrim, sulfamethoxazole trimethoprim, I never see rashes on dapsone. It's literally, I think, maybe 2 cases in my career. But we will give you an H1H2 blocker like cetirizine, Zyrtec, and famotidine pepsid to block histamine receptors, and then start with very low dose dapsone like 25 every other day. And again, methemoglobin is not even an issue at this point. So finishing up this talk, what are the future avenues, therefore, for both Alzheimer's and chronic Lyme disease? So what I would suggest for the Lyme community and also for the Alzheimer's community, establish a cognitive baseline and get your Alzheimer's biomarkers done. Your beta amyloid 42/40 ratios, your p-tau 181, your p-tau 217, your neurofilament light, and you can even look at glial fibrillary acidic protein. If you are amyloid negative, tau positive, meaning you're A minus T plus, which is some of our chronic Lyme patients, they have what's called a tauopathy. This is a critical window where an aggressive Mediterranean diet, aerobic exercise, sleep hygiene can delay symptoms for years. And this is also where you're going to look at using things like broccoli seed extract, sulforaphane, vitamin D, probiotics, and evaluating and treating the 16 MSIDS variables. I would consider the 8 to 9 week double dose dapsone protocol for chronic Lyme PTSD and a minimum of 4 high dose pulses if you have chronic Bartonella. And again, the full protocol is in Microorganisms 2023, and I've been publishing also in my Substack And again, what I did in my new book, Ending Chronic Illness, is break it down slowly like a cookbook that is absolutely clear how to do this protocol and even start and stop if you need to. So to protect your future health and your patient's health, if there are doctors listening, please record pre and post levels of Alzheimer's biomarkers, and then you're going to publish your results after using double-dose dapsone and high-dose dapsone. We need to get this in the medical literature. If you're using other therapies like disulfiram, and I spoke to Ken Liegner about this weekend at a Lyme conference, or herbal therapies, whatever you're using, record these Alzheimer's biomarkers before and after to compare results and understand how what we're doing for the Lyme community is affecting their long-term brain health. This is absolutely crucial now that we know there's something that may be a benefit in this population of patients. Now, you can also use these biomarkers to monitor non-Alzheimer's disease brain health, as we mentioned earlier. You can use neurofilament light as part of an annual wellness check to monitor for subclinical brain damage from high blood pressure, diabetes, or undiagnosed sleep apnea. So you'll see the Quest codes that you'll use here for beta 4240 ratios, p-tau 217, p-tau 181. These are the biomarkers that are easily gotten from Quest Labs. And again, I've been getting about, as I said, about 50% of my patients are coming back positive with either neurofilament light or p-tau 181. And I hopefully will actually have more case studies to be publishing in the future. So in conclusion, Alzheimer's disease and Lyme disease epidemics are overlapping. And there's a reason they're overlapping is it's not just now proven in autopsy studies, but it's been proven for the first time in a live human that these are related, because what I did is I reversed p-tau 217, the most sensitive and specific Alzheimer's biomarker. I reversed it and lowered it by 63% with an 8 to 9 week oral antibiotic protocol, double dose dapsone combination therapy, finishing with 4 days of high dose dapsone. And the infection amyloid p-tau hypothesis is no longer a hypothesis. It's now proven for the first time in Alzheimer's disease. This case study also provides more proof of persistence. This woman was sick for 15 years and didn't do any antibiotics. And 15 years after being sick, we lowered her rheumatoid factor back into the normal range, and we completely reversed her p-tau 217. That is how effective dapsone combination therapy is in hitting the biofilm persister forms of Borrelia burgdorferi. Again, remembering I was still treating these overlapping MSIDS variables. Now, the American Academy of Neurology, the Infectious Disease Society of America, the American College of Rheumatology, their guidelines right now is that if you have dementia with Alzheimer's, don't check for Lyme. They are absolutely wrong, and they need to change. Any patient now with dementia needs to be checked for Borrelia burgdorferi, for BART, for mold, all the MSIDS factors that we talked about today, and all of the chronic Lyme PTLDS patients need to be checked with these Alzheimer's disease biomarkers and MSIDS variables to see how you can improve your clinical status going forward. So please consider using double-dose dapsone combination therapy and high-dose dapsone pulses for chronic Lyme, PLTS, and BART if you have these Alzheimer's disease biomarkers. And again, my next step, and I'm going to be looking for funding through my 501c3, the MSIDS Foundation. You can look it up at msidsfoundation.org. We're looking to do a multi-center placebo randomized trial. In one arm, I will have Alzheimer's patients who've been exposed to Lyme disease with these elevated biomarkers. In another arm, we'll have chronic Lyme disease patients who have these Alzheimer's disease biomarkers, and we're going to look at the MSIDS variables in both groups, and it will be placebo-controlled. So in other words, the dapsone will be placebo, and we'll also see whether, in fact, a tetracycline, rifampin, zithromax, and methylene blue can still be helpful without dapsone. I mean, this is an essential study that needs to be done because, as I showed you, 42% of people over 55 years old are now expected to get Alzheimer's disease. So to keep up with what I am doing in medicine, please consider subscribing to my Medical Detective Substack. It is free to sign up. You can just point your phone at the QR code here to scan in and subscribe. I'll give you weekly insights on chronic illness. And finally, you can pre-order Ending Chronic Illness today. If you scan in the QR code there, you can get 15% off by putting in the code Richard15. This will be available up until the time that the book goes on sale, which is October 13th of this year. And I can get you signed book plates, but as I told Leah, if you're looking for signed book plates, please consider getting, because the book's out in October, maybe consider buying 4 or 5 copies for Christmas for people for the holidays. Give me their names, exactly how you want me to write this out. I need a self-addressed stamped envelope with the names of how you want this addressed and proof of purchase. But hopefully I will be able to get these signed book plates in the mail to you. So thank you. We'll take a couple of questions. But I think today, hopefully, we've given you some information that you've never had before in chronic Lyme and Alzheimer's. And I honestly think we are entering at this point a new era of medicine where you can have hope. It's no longer you must stay ill from chronic Lyme. It's no longer, in my opinion, you must stay ill with dementia. We have new ways now of helping people. This gives us hope. And I'm really so excited to share with you today. So thank you so much for attending, and we'll take a couple of questions.
Okay, I guess I'm there. Well, there was an awful lot of information there, exciting information, but something that we're going to want to reread. So I'm just, or go over again. So I want to let everybody know that the recording for this will be available very soon, probably tomorrow, and we will send all that information out. And I have a lot of questions. One of them, I realized that you answered when you listed the various tests with the codes, and we will include that information when we send it out because there's a lot of people that want to know that.
Yes, and in the 6-part Substack that I just did, my 6th one will be tomorrow. And then I'm going to start looking at hantavirus. But the 6th part actually ends tomorrow. If you go back in the Substack series that I did, all of those codes are in there also.
Okay, good. So that answers some of the questions. So one thing that somebody says, after someone has recovered or significantly improved, what steps are most important to prevent relapse or long-term complications?
So the thing for me that I was telling about in the slide presentation about relapse is most of the patients I saw that did not go into remission from the initial 9-week dapsone protocol, they all had babesia, they all had chronic Bartonella, and most of them all had mold toxins. I'm talking 90%. Now, it doesn't mean they also didn't have leaky gut and vitamin mineral deficiencies and sleep disorders and trauma, all the MSIDS factors. But the top things that interfered with the success of this 9-week dapsone was babesia, Bartonella, and mold, along with heavy metals. So again, I found this protocol to be extremely effective. When my wife, many of you may know, my wife was my guinea pig for this dapsone protocol years ago. She took 50 milligrams of dapsone for 1 year and felt great. Said, my brain's clear, I feel great. She stopped it, relapsed, and she was PCR positive for Lyme in her blood. She then did 100 milligrams of dapsone for 6 months. She said, honey, I feel great. We stopped it. She relapsed. We then did 1 month of double dose dapsone. And by the way, I will point out in this discovery, the way I made this discovery, I should have told you this, it's really a great synchronicity, is one of the patients came into my practice and said, oh my God, doc, I'm feeling horrible. I'm having these herxes. I've got pain. I've got fatigue. I've got brain fog. I said, oh, what are you taking? He said, oh, I'm taking dapsone 100 twice a day. I went, oh my God, you're taking twice as much as I told you to take. Stop it. 3 months later, he was in remission with his brain clear. 6 months later, he was in remission. 9 months later, the way I discovered this is my patients made mistakes. The same thing, by the way, with the high-dose dapsone with 400 milligrams. One of the patients was supposed to take double dose. She took the high dose for several days. She said to me it was the herx from hell. I took her off the protocol. She was in remission. I looked at it and I went, oh my God, for Bart, I need higher doses of dapsone and methylene blue to treat the Bartonella. That the double dose dapsone was fine if you only didn't have active babesia or Bart. But the double dose dapsone is not enough with mold, babesia, and Bartonella. So this is really the key. If you keep relapsing and you've got day sweats, night sweats, chills, flushing, air hunger, chronic cough, classic symptoms of babesia, and you have failed atovaquone and Mepron, and you failed Malarone, and you've failed all the herbs out there, the tafenoquine protocol that I showed you in the slides, I'm having about an 80% success rate. And by the way, dapsone combination therapy hits babesia effectively about 25%. About 1 in 4 people, their babesia is better just by doing dapsone because it has anti-malarial effects. When I was looking up about the drugs 10 years ago to use for Lyme, when John Hopkins said Lyme is a persister bacteria, I knew that it persisted. They meant it persisted like tuberculosis and leprosy. So when I looked up the qualities of dapsone, I saw, oh, it's anti-inflammatory. It hits autoimmunity, which we see in Lyme, has great central nervous system penetration. It hits the persister forms of the bacteria, right? It kind of was checking all the boxes, and it's anti-malarial. It had 5 boxes checked, and I went, oh, this looks like it's going to be a home run. And it was from day one. It just took me a decade to figure out the dosing and how to make it safe by giving more folic acid to lower the anemia and more methylene blue glutathione to keep down the methemoglobin. It took me a decade to figure out the protocol that I'm presently using, which is in Ending Chronic Illness, which was published in Microorganisms. But if you keep relapsing, it's probably because you have active Babesia, BART, or mold, or other MSIDS variables if you've gone through the 8 to 9 week dapsone combination therapy. I've had, again, I was at a Lyme gala this weekend, and I was seeing a woman with a PICC line. And I asked her what she was doing, and she said to me, her doc has her, for the moment, on ivaclinda because she's got Babesia. And I went through with her some of the options, and she was afraid to use dapsone because of what she's heard about in, the Lyme community about the safety. And it's like, I needed to do this presentation for you. I would never give a protocol that my beloved wife would not take, that I didn't think was safe, or that I myself would not take. And it's never been a reversible. If you had lung cancer and you took chemotherapy and I knew I could put you in remission, you're going to have long-term chemo brain fog and probably long-term chemo neuropathy. There are no long-term side effects from doing dapsone therapy if you follow the protocol the way that it's published in the medical literature. So please, folks, it's taken me 41 years and seeing 13,000 patients to come up with this protocol. If you're still sick and you've not done it, please, and your doctor doesn't know it, have your doctor look at the Substacks, have your doctor contact me. I'm happy to help them with this. Get Ending Chronic Illness, but please don't deny yourself what I consider to be the shortest term oral, most effective protocol that maybe will prevent issues with brain health later on. Again, this is one case study. I can't go too far in what we want to talk about with this, but the number one effect from dapsone, if you look at all the 11 studies that were published, number one was always cognition. Memory, concentration, word finding, 70% of the patients always reported it was the most statistically significant effect. And that figures now that I'm seeing these Alzheimer's biomarkers reverse. So hopefully that kind of gives you a clue. And that's why, by the way, I included the slides of, who are my most chronic patients, the ones with chemical sensitivity, the microbiome issues. Those are the things you need to be looking at.
I think that's enough for now, but thank you. As I said before, this is a lot of information for us to wade through, and we so appreciate everything that you've done and having this explanation for us and making your material available on the Substack and your forthcoming book. You're a rock star. Thank you very much.
Thank you, Dora. Thank you for all the work you've been doing with LymeDisease.org and all the organizations out there. And again, thank you to Monica Embers and Eva Shoppe and Alan McDonald, all the researchers, John Hopkins. If it wasn't for you, I would not have discovered what I discovered. So really, just like early on, I was on the shoulders of the giants like Joe Borscano and Ken Liegner and Sam Donta. By the way, Sam contacted me and is willing to be part of the brainstorming group, by the way, with this Alzheimer's study. And Sam and I are going back and forth. But I was standing on the shoulders of these giants. And now these researchers who put out, the research on the biofilms and the persisters, and I could not have done what I did today and showed you today if it was not for them. So please consider always giving generously to the Lyme organizations who are doing this amazing research, because I would not have been able to share today what I did if it wasn't for them. So again, thank you, everyone.